I think that this issue of how to manage acquired resistance, we didn't get a lot of new information at this meeting, but I think it's a really vexing issue. I had led an educational session on this, and there was a lot of attendance and a lot of energy around it, I think, because it's just such a timely issue that we all struggle with, particularly with EGFR inhibitors, where we have 10 years of experience of good responses followed by acquired resistance, and still nothing is clearly optimal as an approach. And there's questions about, do you continue these agents beyond progression? Because an implication of developing metastases in the brain, if the drug isn't getting in the brain but you have great control everywhere else, is continue the drug for everything that is being controlled outside the brain, and then just do whatever you need to do radiation-wise, for instance, to treat the brain mets. But Mary, what do you do for acquired resistance? Do you commonly continue the agent? Do you add in chemo? Are there other avenues in terms of clinical trials that you do or are excited about?
Yeah, I mean, I think definitely clinical trials are my first choice if that's an option, but in many cases it's not. Either trial's not available or the patient isn't a candidate. And so it kind of falls into a couple different categories. I think in many cases, if they have asymptomatic slow progression, I might not do anything. I might just continue the drug and watch them closely. If they have a solitary site that's symptomatic, or they have CNS disease, I'll usually treat that with radiation.
And keep the same
And keep the therapy going. If they have florid progression of disease, in many cases, I will stop the therapy and move on to chemotherapy. Although I typically, I think I've seen some patients who've really flared if you stop the treatment before you've got something else to back up. So I typically am very cautious about stopping it, even if they've had significant progression, until I've got the next therapy lined up. Mm-hmm. So that's kind of my approach.
And do you add chemo to ongoing TKI, either for some combined effect against both the TKI resistant and the targeted therapy responsive disease, or just to prevent the flare at all?
In some cases I do, absolutely, yeah.
I think you bring up a very good point about the slow progression doesn't necessarily mean reflexively abandon the drug, because these are drugs that you could still be getting a good response, relatively speaking, and a couple of millimeters of slow progression every few months is not a reason to throw out the baby with the bathwater. I mean, one of the analogies that I've used on the GRACE side a long time is bad breaks are better than no breaks, and that may be the choice where you're choosing between having very slow progression of the disease versus much faster.
Right, and with a limited number of agents, the more mileage we can get out of each of these really, I think, helps the patient.
Nate, I'll welcome your comments here, but also particularly about rebiopsying in this setting, because I know you've had some thoughts and we've had some discussion about the relative merits of that and how actionable are the results.
Well, so from the standpoint of what I do in continuing or stopping the targeted agent, we actually presented a trial that we did in Cleveland this ASCO called the erlotinib Beyond Progression trial, where patients who had progressed on erlotinib were then randomized to either stopping the erlotinib and starting second-line chemotherapy with pemetrexed or continuing their erlotinib. And although we had to halt the trial early because pemetrexed isn't used second-line much anymore, in our limited subset there wasn't really any suggestion that people did any better whether we stopped it or started it. So I do continue it right up till the day before they start chemotherapy, because I've seen the same thing where they could just start coughing and getting very quickly after stopping the drug. But I usually don't continue it. In terms of new biopsies, though, I have started routinely biopsying everyone who progresses, who is on certainly an EGFR tyrosine kinase inhibitor, who I know they have a mutation, or I suspect they have a mutation. One, because it would be great to put them on a trial, and a lot of trials require that you do that to document whether they have the T790M mutation or not. But the other thing that I have really noticed that I never believed until I saw it with my own eyes is this transformation to small cell phenotype. I don't know if you guys have ever seen that, but I had 2 patients in a 6-week period, both of whom had very indolent disease, were treated, and some of them I was continuing on treatment even beyond when they were starting to maybe grow a little bit. But suddenly the next scan 6 weeks later, and they had huge progression of disease, and I biopsied it, and it was small cell. And it actually had the same mutation that the original cancer had.
As they say you will see, yeah.
Yeah, exactly. And one of the patients we treated and is doing very well. The other patient, it didn't respond to anything that we gave it. But I do think that routinely biopsying, even in the community when you don't have a trial to be available, if you're suspicious that it just doesn't seem right, it can help determine what's going on and maybe even help with the treatment.
I think that's the most obvious actionable result, and it's a minority of cases, but you don't know unless you test, and I think that I was impressed by your personal, I haven't seen it with my own eyes yet, but part of that is because I haven't had as many patients with more florid progression recently, but it's something I'd factor in.